today, as we usually do. We have Kristina Cosley, who's a physical therapist here at Harborview Medical Center with UW-Medicine. She practices physical therapy here at Harborview, works with a variety of patients, but a large part of her work is with older adults, and she is the physical therapist for our fall prevention clinic here at Harborview, which is a multidisciplinary clinic run by Dr. Elizabeth Phelan. So I'm so glad that you're here to talk to us about something that is uncomfortable for a lot of medical providers, which is gait assessment. So thank you so much for being willing to do that.
Thank you. Thanks for having me. I'm excited to share with you just a little bit about gait and balance. Gait can be tricky and there's a lot to it, but my goal is to be able to leave you with some ideas for what is normal gait and what might be deviations or when your patients might be having difficulty with gait. We'll also touch a little bit on just the basics of cane use and then finish up with the balance part, which will be related to fall risk screening in your patients that are 65 years and older, looking at what are the best subjective questions and objective tests to do to give you more info. So we'll see the gait screening portion of this. Everyone's gait is going to be a little bit different, but my goal is that you'll have a nice systematic approach to look at someone's gait. Now you can divide it into a couple different areas. You can look at it in terms of what's happening in each plane of movement, or you might be able to look at it in terms of, well, what happens in the stance phase when the leg is in, the foot's in contact with the ground, and then what's happening in the swing phase, whichever is easiest for you. So we'll go through these briefly, and then we're going to show a video of normal and some common gait deviations that you'll find in clinic. In the frontal plane, this is probably best observed if you have your patient walk away from you and then back toward you. And it's easiest to observe the stance phase in this way. So you can look to see if someone's spending a symmetrical amount of time on each foot, or does that look different and asymmetrical? Does the patient look like they want to shift their weight off of their foot in terms of maybe having an antalgic or painful gait? Do you see one side of the pelvis drop as they're standing on their leg? In the sagittal plane, this is easiest to look at if your patient's walking past you, back and forth, and probably easiest to look at the swing phase of gait in this method. So you'll look to see how long their step is. Is it equal side to side? Are they dorsiflexing their ankle enough so that they're clearing their toes and they're not tripping on their feet? And you can also see when that foot comes into contact with the ground. Their heel should be hitting first, but you may see someone who just sets their entire foot down or touches their toe at initial contact. And then at the end of the stance phase, you can look to see, are they propelling themselves forward effectively enough? Is their push-off effective? And you may notice foot drop, which is when there is weakness preventing them from actually lifting their foot up and clearing their toes. It's also a good time to just check overall their posture. And I think as patients get older, we tend to see more of a forward flexed, kyphotic posture. And you can look to check in on how they're using their assistive device, where they flexed over their device and holding it way out in front of them. They might need some extra training. And then lastly, looking for spine rotation. As you're looking at them from behind, probably easiest to visualize there is one shoulder coming back and one forward. Are they swinging their arms? I know clinically I'm seeing that in older adults, they have less spine motion and that arm swing is reduced. So when you're screening your patients for gait and taking a look at them, always make sure you note if they're using an assistive device or not. That's always helpful. And if you think that they might benefit from a cane, I think you're going to see a lot of cane use in your practice. Remember that a cane is more of a minimal supportive device. So it can support about 15 to 20% of a patient's body weight. And if you're thinking they could benefit from it, if there's someone who has more mild deviations, you could take them out into the hallway and just do a quick test where you hold their hand. And if they benefit from just the bit of support provided by your hand, it starts to normalize their walking and potentially helps alleviate some of their pain, they might be a great candidate for a cane. I'll refer you to some of the supplemental materials that we're going to send out. There's a quick article on choosing the correct walking aid. And this also will explain how to size or fit the cane for people, and I think that'll be useful for you. So the big question is, if you determine a patient could benefit from a cane, and let's say they have like right knee OA and pain when they're stepping on their right leg, what side would you tell them to use it on? Would you have them use it on their right side or their left side? The answer would be their left side, and that's not always intuitive. So you want to give it to them on their unaffected side, and that's really for a couple reasons. It'll help reduce the forces on that painful limb by about 2/3, and it also helps normalize their walking pattern. So in normal walking, we advance our opposite arm and opposite leg simultaneously, so they can maintain that normal gait as much as possible if they're using it in that way. Okay, we're going to show you a quick video. It's actually several minutes long, but you're going to see some normal walking and then some really common deviations.
In today's tutorial, we will cover an approach to gait. We'll first have a look at normal gait and then cover the following abnormal gaits. So let's kick it off with normal gait. Normal gait involves the smooth coordination of the pelvis, hip, knee, ankle, and foot. This is effected by appropriate neurological commands and the movement of many muscles and joints. It is broken up into two phases, the first being the stance phase. The stance phase constitutes 60% of the gait cycle. It starts with heel strike, during which the foot and ankle are dorsiflexed, the knee is extended, and the hips are flexed. Controlled relaxation of the dorsiflexors at the ankle allows the foot to flatten. During mid-stance, the body weight is centered over this foot before being propelled forward. At toe-off, the ankle and foot are plantar flexed, the hamstrings are flexed, and the hips are extended. The hip abductors play an important role in pelvic stability. By tilting the pelvis upwards on the opposite side, they allow weight to be bared exclusively on the leg in stance. This prevents one from falling over. The swing phase begins with toe-off. This is followed by pre-swing, during which contraction of the hip flexors allow the leg to begin swinging forward. During mid-swing, the foot and ankle are dorsiflexed and the knee is flexed, allowing the foot to clear the ground. During terminal swing, the knees are extended and extensors of the hip contract to decelerate the swinging of the leg just in time for the next heel strike. The heel strikes the ground, completing the gait cycle. And now, let's have a look at a few abnormal gaits. First up is equinus. Here we want you to notice how she tiptoes on her left foot. This is because she can't dorsiflex, and as a result, she can't strike the ground with her heel. Equinus is seen in cerebral palsy, tightness of the Achilles tendon, and limb length discrepancy, amongst others. And now for drop foot, otherwise known as the high steppage gait. Notice how she raises her right knee higher during the swing phase in comparison to the other knee. This occurs because paralysis of her foot and ankle dorsiflexors in this leg prevents her from clearing the ground properly, and so she compensates by excessively flexing the hip and knee to achieve this. This is seen in direct injury to the dorsiflexors and deep perineal nerve palsy, as occurs in diabetes, sports injuries, childbirth, and hip or knee replacement. And now let's have a look at antalgic gait, or what we like to call the quick step. Because her right leg is painful, the duration of stance on this leg is shortened, and thus so is the swing phase of her normal leg. This produces a quick step. With regards to causes, there are many. The Trendelenburg gait. This gait is best observed by looking at her shoulders. During the normal gait cycle, it is supported. To allow for this, the hip abductors of this side work to stabilize the pelvis by tilting it slightly upwards on the opposite side. When this abduction mechanism is not working, the pelvis drops on the opposite side, and as a result, some weight is still bared on this leg. This would otherwise result in a fall, but as demonstrated in this video, our model stops herself from falling by throwing her weight over to the affected side. This is observed by viewing her shoulders, which drop towards the affected side. Less obviously, you might also be able to see her pelvis dropping on the opposite side. It is important to perform the Trendelenburg test to complete this. This is caused most commonly by weak abductor muscles, as seen in L5 radiculopathy. Other causes include dislocation of the hip. And finally, the short leg gait. Here, we have simulated a limb length discrepancy by wearing a high-heeled shoe. But ignore that for now and have a look at her head and shoulders. What we want you to notice is how her shoulders stay leveled whilst her head bobs up and down as she walks because of the difference between the lengths of her legs. The abnormal leg is typically the shorter, but can also be the longer leg, and the pathology may lie in her tibia, her femur, or these are distinguished with full exam of limb length discrepancy. Causes include congenital hip dysplasia, hemiatrophy, growth plate injury, and chronic osteitis. So that brings our tutorial to the end.
Okay, so now that we have that, none of us can go to Pike Place Market or the airport without analyzing gait and noticing those things out of the corner of your eyes. I wanted to show you this quick picture here because this wasn't covered in the video, but this is another common deviation that you'll see, which is circumduction of the hip, where instead of just advancing the leg forward, the person will bring their leg out to the side and then place it in front of them. And you'll see this in more larger scale neurological dysfunctions, possibly after a stroke. This is just a great picture of what's happening in Trendelenburg. I wasn't sure if it was very clear in the videos, but when you're on that stance limb and the opposite side of the pelvis drops because the hip can't support the weight. And this is actually the test too that you could do and just observe in the clinic. So we'll switch over to talking about balance as it pertains to fall risk screening in your patients that are 65 years and older. And this isn't a new topic. This is obviously a major health concern. And we all know that patients 65 years and older are at about 25 to 30% chance at risk of having a fall. And we know that falls are preventable. So we'll talk about some screening and objective tests as I found in the literature. Our screening questions are going to stay the same. I think that we're all pretty familiar with these three questions. Have you fallen in the last year? Are you afraid of falling? And do you feel unsteady with your walking or balance? If they answer yes to any of those, in our PT world, we are required to do at least one more objective measure when we're screening all of our patients. So we're going to look at the best and just most supported in the literature. And those tests are the timed up and go, the 30-second chair stands, and then the 4-stage balance test. We're going to come back to this slide, but I wanted to tell you just really quickly where I'm gathering my information from. And this is all going to be in the supplemental material, but this is the CDC's latest algorithm on fall prevention screening and intervention. And I think they've streamlined it a little bit from their last version. Now it's just people are at risk or they're not at risk. And so I'm getting information and synthesizing it both from the CDC and a research study. And I encourage you to go over to the cdc.gov. They've got great information on fall prevention, how to implement it into your practice, as well as some great patient materials. The other big place I'm getting recommendation information from is this study done by some physical therapists, and it was published in the Journal of Geriatric Physical Therapy in 2017. And they set out to basically look at what screening questions and what objective measures are going to give us the highest post-test probability of determining if our patient's going to be at risk for a fall. And they came up with the fact that there is not one test, which is pretty easy to understand, and it's going to be a combination of tests, objective tests and subjective screening questions. So the tests they found that gave them the highest probability of determining fall risk in patients 65 years and older are listed here in blue. The Berg came out with the highest percentage, though for me the Berg is kind of like a mini physical therapy evaluation. So for screening purposes, I don't know that this is going to be the best use of your time. And I would just head on down to the next 3 tests to still give you some really great information. So if we summarize here in terms of fall risk screening, we're going to continue asking those 3 standardized questions of our patients. And then it's best to pick at least one objective test. However, the more you do, the more information you get. The timed up and go is going to give you information on their functional mobility and dynamic balance. The chair stand test will give you a great test for functional leg strength. It's going to be very different from your manual muscle test. You'll find they turn out differently sometimes. And then the 4-stage balance test, you can actually just focus on that single leg balance portion of it, and that'll give you some great info on static balance. And if you need some additional information to really help determine if your patient's going to be at risk for having a fall, there are some additional screening questions that include if they need assist at home with daily activities, if they need to use an assistive device, or if they're taking any psychoactive medications. So we're going to show you each of those 3 tests so that you can try them in clinic.
The 30-second chair stand tests functional lower body strength test. You'll need a chair with a straight back and a stopwatch. Place the rear legs of the chair against a wall so that it cannot slide backwards. Have your patient sit towards the front of the chair and fold her arms across her chest. Ask her to keep her feet flat on the floor and sit upright. She should try to stand up, keeping her arms folded across her chest without pushing off with her arms. When you say go, she should stand up all the way and then sit back down, doing this as quickly as she can until you say stop. Arms should remain folded across her chest throughout the test. Stand close enough so that you can catch the patient if she loses her balance. If the patient gets tired, she may rest, but let the time keep going. If she cannot stand even once, the test score is 0. Not being able to stand up from a chair without using one's arms to push up indicates a high risk for falls. Record the number of times the patient stood up in 30 seconds. If the patient is over halfway to a standing position at the end of 30 seconds, count it as a stand. Now, based on the age and sex of your patient, find their normal range on this chart. If your patient score is below the norm for his or her age and gender, it indicates lower body weakness, a risk factor for falling. If the patient can't stand up even once without using her hands, allow her to push off using a hand on the chair. Be sure to document any adaptations. The test score is still 0 for purposes of comparing to normative standards. Performance can be evaluated from one assessment to the next. I find this test is very helpful for monitoring the effects of strength training. It's also useful for motivating patients because they can see how much they improve by doing strengthening exercises on a regular basis. The timed up and tests functional mobility. To perform the test, you need a chair and a stopwatch, or a wristwatch with a second hand. Have your patient start by sitting on the chair, feet flat on the floor, one foot slightly in front of the other, and hands on the armrests of the chair. Put a line on the floor 10 feet or 3 meters away. Ask your patient to stand up from the chair and walk at her normal pace to the line on the floor when you say go. When she reaches the line, she should turn around, walk back to the chair, and sit down. Be sure to start timing on the signal go, and even if your patient has not started to move, and stop timing at the moment she sits back down in the chair. While she's walking, stand between the chair and the line in case the patient loses her balance and you need to assist. Observe and note the patient's posture, width of the base of support, step height, stride length, arm swing, and path. When the test is complete, record the time. Also record whether the patient used an assistive device, and if so, what type. A community-dwelling older adult who takes more than 12 seconds to complete the tug is at increased risk of falling. The 4-stage balance test assesses static balance, which is an important part of postural stability. To perform the test, you only need a stopwatch. Tell your patient
Hi folks,
you will
I'm
show
Bob
her
Schrupp,
4
physical therapist.
positions
Brad Heineck,
and would
physical
like her
therapist.
to try
the
and
most
stand
famous physical
in each
therapist on the
position
internet.
for 10
In our opinion,
seconds.
of course, Bob. Brad, you wanted to talk today.
Sorry about that.
Assesses static balance, which is an important part of postural stability. To perform the test, you only need a stopwatch. Tell your patient that you will show her 4 positions and would like her to try and stand in each position for 10 seconds. She can hold her arms out or move her body to keep her balance, but should not move her feet. For each position, describe and demonstrate it, and then stand next to her and hold her arm if needed to help her assume the correct foot position. When your patient is steady, you can let go. Say ready, begin, and begin timing. But you should stand close enough so that you can catch her if she loses her balance. After 10 seconds, say stop and record the time she was able to hold the position. If a patient can hold a position for 10 seconds without moving their feet or needing support, go on to the next position. If not, stop the test at this point. For the first position, the patient should stand with her feet side by side. For the second position, she should place one foot so it is touching the instep of the other foot. For the third position, she should place the heel of one foot in front of the other foot, touching the big toe. For the fourth and last position, have the patient stand on one foot. An older adult who cannot hold the tandem stance or either of the 2 prior stances for at least 10 seconds each is at increased risk of falling. Thank you for taking the time to learn these important tests of gait, strength, and balance. We hope that you'll use these tests along with the other information in the STEADY Toolkit to determine whether your patient is at risk for falling. By doing this, you can reduce your patient's chances of falling and experiencing the devastating consequences that often result from falls.
Okay, and there's some handouts that will be coming in your supplemental material as well on how to do these tests. Got through all those, a few references for you, and then just a thank you. I hope that you have some really good clinical information you can take and implement in your practice immediately.
Great, thank you for all of that. I don't know how you fit that into 20 minutes, but that's amazing.
I told you it was going to be longer than 15.
It's impressive.